I'll be taking you through fetal growth assessment, obstetric Dopplers, and clinical application. But my first port of call, so my presentation outline will be focusing on three main areas: pregnancy dating, assessment of fetal growth, then finally I'll be touching on how Dopplers can be utilized in obstetrics, as well as the clinical applications. All right, so I'll start with pregnancy dating. So we've got non-sonographic or traditional methods of dating a pregnancy. This is more like assigning dates and an EDD to the pregnancy. So we all know about the menstrual period, the LNMP, but it is based on some assumptions. One of the assumptions is that the woman should be having a regular 28-day cycle, and the other assumption is that ovulation will occur on day 14, but this doesn't always apply in all women. And another finding from a study which was done in America was about 50% of women are uncertain of their periods. And in Zimbabwe, our local data proved that about 60% of women were uncertain of their dates. So which makes it a bit unreliable to just use the last menstrual period. Then we've got, I'll move on to the dating using IVF, which is more like the gold standard, because it's done under controlled environment. It's known when the fertilization would have taken place. So this one is guaranteed that the date is more accurate. So when a woman comes, we don't change their dates when they have an IVF EDD. Then in terms of ultrasound methods, two main methods which are used in the first trimester. We've got the mean sac diameter. If the pregnancy, the fetal pore is not yet appearing. So you measure the gestational sac in 3 planes, then the average is what is used to date the pregnancy. Then afterwards, when the fetus or the embryo is now visible, then we use the crown rump length, which is like the gold standard with a very minimal margin of error. Then from the second trimester onwards, we use the head circumference. That's the standardized method of dating a pregnancy. So you use the head circumference. You don't use the biparietal diameter. You don't use the average ultrasound age, which is given by the machine, but you use the head circumference in the second trimester. It's not recommended to date a pregnancy in the third trimester, because in the third trimester, some factors would have cropped in, which might lead to you missing probably a fetal growth a restricted baby. So in the third trimester, what you can do is you can actually assign a gestational. Let's say a woman pops in the third trimester, no scan, nothing, they don't know their LNMP. You do the head circumference, not to date the pregnancy, but to assign a gestational age. Then when you do the other measurements, then you can compare to see if there is symmetry or asymmetry in the measurements, which will help you. Then you can do some growth intervals afterwards, which I'll be talking about in subsequent slides. All right, so once we have our EDD, it's more like you have your birth certificate. When you have your birth certificate, the teacher or the teacher cannot change to say this one is a short student, therefore, even though the student is in grade 7, we now say this is it's now in grade 3 because it's short. Or probably because they are tall, they are in grade 3, then you say it's now in grade 7 because they are tall. So once an EDD has been assigned, it's cast in stone, and any subsequent scan which is done should take into consideration that gestational age. So you shouldn't redate a pregnancy. I think one of the common practices, especially in the sonography and radiography world, was every time a woman would come, they would be given a new due date. And sometimes it would be going forward, sometimes it would be reversing, sometimes it would actually make the woman happy to say, yeah, I think that one aligns with the birthday of the great uncle or something like that. So the ideal thing is once an EDD has been assigned, we stick to that so that we can pick if there is growth restriction or overgrowing of the baby. Then we should not use the average ultrasound age which the machine gives. I think that was another cardinal sin which was being committed, whereby the machine averages the measurements, the head, the abdomen, the femur, and it gives you an age, and you give that. Because what happens if a baby or a fetus is undergoing fetal growth restriction, then it will tend to underestimate the size of the baby, and it can have some adverse consequences on the pregnancy. Then, so instead of changing the due date, once a pregnancy has been dated, the subsequent scans are to measure interval growth or assign what we call percentiles, which I'll be talking about in the next coming slides. But there are some instances whereby you might need to redate a pregnancy. Usually, this happens when a woman says, they come to you and they say, I'm confident of my LNMP. Then you do the pregnancy dating using the head circumference, and you see that their date and what you are getting from the head circumference, and if it's between 14 and 16 weeks and there's a discrepancy more than 7 days, then you need to redate that pregnancy, and you give them the gestational age, which is consistent with the head circumference. You disregard their LNMP. Remember what we mentioned about LNMP, that it's based on assumptions. So if it happens between 16 and 22 weeks, and there's a discrepancy of give or take 10 days, then you also redate the pregnancy using the ultrasound head circumference. 22 to 28, give or take 2 weeks, you redate the pregnancy using the head circumference. Then greater than 28 weeks, the discrepancy more than 28, we do not encourage redating pregnancies in third trimester for the reasons I alluded to earlier. So I now move on to fetal growth assessment. So now we have a date. We've got an age as a certified gestational age for the pregnancy. Now, the next scans, what they are supposed to do is to assess how the fetus is growing, which is the growth assessment. So, it requires at least 2 assessments separated in time. I think probably something I need to quickly highlight is when you redate the pregnancy, you don't do the percentiles, which I'll be talking about now. When you redate the pregnancy, because the machine will give you percentiles after redating a pregnancy, you don't assess growth when you have redated a pregnancy on that particular appointment. Because now you have assigned a gestational age. So what you can only do is probably say, come after 2 weeks or after 3 weeks. Then you can now do the growth assessment. So I think it speaks into point number 2, that it requires at least 2 assessments separate in time. Then the same biometric parameters should be used to assess the fetal size, are the ones which have to be used consistently. I think Dr. Verga talked about standardization. So it's very important to standardize things at a personal level, so that, you know, when you scan the same patient, probably within the same appointment, you can get different figures which can actually change the whole configuration. So it's good to standardize at personal level, but it's also good to standardize at a national level. And this is why the different parameters have to be measured at specific points, which I'll be touching on in the next slide. So I think we've preached this gospel several times about the correct plan for the head circumference and the features which need to be seen on the image. The same applies for the femur. Not everything round should be measured to say this is the head circumference. There should be some landmarks which should satisfy the conditions of an ideal image. The same applies for the abdomen. Not everything round in the abdomen is the abdominal circumference, but those landmarks should be fulfilled. So does the fluid, which is part of growth assessment. So I'll talk about the fetal growth categories. So we've got 3 main categories of growth. Remember, we now have a gestational age. Now we are assessing growth in subsequent scans. So we've got what's called the appropriate for gestational age, which is the widest range, which ranges from what's called the 10th percentile to the 90th percentile. So probably within the graph is the one which is falling within the middle, that middle category there. So when the growth is between the 10th and the 90th percentile, we say it's within the appropriate for gestational age range. When the growth is below the 10th percentile, we say it's more for gestational age, and when it is above the 90th percentile, we say it is large for gestational age. So this is what was happening when the dates were being forwarded or reversed when people were still in ignorance. So now you know that what will be causing the date to be moving forward is probably the fetus is growing small for gestational age. What was causing the gestational age to be coming nearer was because it was going for large for gestational age. All right. So I'm now changing gears slightly. I know my presentation is better than the unemployed because that one I saw most people were frowning. All right, so I'm slightly changing gears, moving on to the Dopplers. So Dopplers, you know, a modern scan machine or a modern person who does scans, whether they are a midwife, a registrar, or whoever, with a scan machine which doesn't have Dopplers, I think it's something which is not recommended for standard obstetric scanning and management of pregnancies. So every machine should have some Doppler facilities, and I'll be just taking you quickly through the different types of Dopplers. And the role of Dopplers mainly is for antenatal monitoring of high-risk pregnancy with the aim of preventing perinatal death and handicap. So Dopplers play an important role, not just the biometry which we started with. So on the maternal side, we've got the uterine artery Dopplers, which should be a low resistance type of flow when it is normal. That is what you are seeing on the left side of the screen. That's a normal. You can see, how do you tell that it is normal? The peak systolic, that cap there, or that tip there, will be closer to the end diastolic flow where the heart is relaxing, that lower part. If they are closer together, even before you measure it, you should be knowing that this is a low PI or low resistance within that vessel. Then when it becomes abnormal, then you start having those skyscrapers. You can see now there is a considerable difference between the peak systolic and the end diastolic, which means that the resistance is increased there. And you can see there is also notching. Notching is that bump which is happening during the end diastolic flow. Something which I just need also to highlight there, notching doesn't always translate to a high PI. You can actually have a normal PI with notching. So it's not always that notching is associated with high PI in the uterine artery. Umbilical artery Doppler, I think most of you love this one because it is the easiest. The only downside of it was most people, I think when we were taught before I started the fetal medicine thing, we were just taught to report the resistive index. To just say the resistive index is 0.88, then full stop. And it actually confused the obstetrician, who was also already confused. Because it didn't mean anything to just give numbers. Just like what Dr. Shiruma was doing, giving us those predictive values. I was just saying 0.2 times 5.0, what does it mean? So, so the resistive, the umbilical artery, the most important figure actually is actually the pulsatility index. The pulsatility index, how is it different from the resistive index? It has to do with the formula. So the formula for the resistive index is the peak systolic minus the end diastolic divided by the peak systolic. So when there is absent or flow, it always gives you 1. But it's different now from the pulsatility index because it is the peak systolic minus the end diastolic divided by the average of the two. So you always have a figure which is not infinite like 1. So this one, when it is normal, it is just like the uterine artery. This is now the baby side of the placenta. So it measures what we call downstream resistance. So what happens, the mother should flood blood to the placenta when it's working normally. Then the baby should also not struggle to take. But how do they take? They first should take that blood to the placenta, and there shouldn't be much resistance at the level of the placenta for them to take back the blood through the umbilical vein. So when it is normal, the peak systolic and the end diastolic should be closer to each other. When they become abnormal, then that's what you are seeing on the right side of the screen. It starts by having decreased end diastolic as it continues to deteriorate. Then you end up having absent or flow during diastole and ultimately reversal of flow. So this was deterioration in one patient. You can see on the right side of the screen those graphs. It started good, then the decrement in the end diastolic flow, absence, and ultimately reversal of flow. MCA is found in the circle of Willis. So the umbilical, you do a free loop. I think there was a question which was constantly being asked yesterday, where do you measure the umbilical artery Doppler? You don't measure it at the cord insertion. You measure it on a free loop. Free loop which is free floating in the amniotic fluid. You only measure it at the cord insertion for multiple pregnancies. Because in multiple pregnancies, you don't want to mix up sometimes the cords might be near each other. So in multiple pregnancy, that's when you can measure it at the cord insertion. The MCA Doppler is measured in the greater wing of the sphenoid bone at the base of the skull. And all these Dopplers we have talked about use a gate size of 2 millimeters. That's the ideal gate size. MCA, when it is normal, it is a high resistance vessel with those peaks. The peak systolic and the end diastolic will be far away from each other when it is normal. Then when it becomes abnormal, then they approach each other, what we call umbilicalization of the MCA. It now becomes more like the umbilical artery with close proximity between the peak systolic and the end diastolic. Ductus venosus, an important blood vessel which is used in the first trimester. It's one of the additional markers for aneuploid screening, but it also plays a role in assessing how the level, the pressures of the heart. So when it is normal, it's more like a molar tooth like that. When it becomes abnormal, then there's a reduction in the A wave on the top, on the right side. Then there's a reversal. Then you can see there's even further derangement on C there. So what are the clinical applications of Dopplers? I think it has already been alluded to that in the first trimester, we use Dopplers to screen for preeclampsia using the uterine arteries. Then we also use the Dopplers also in combination with the other tests which were mentioned. Then we also use them for fetal growth restriction screening, which is done in the first trimester, and some remedial actions can be employed, like the aspirin, which was talked about. It's also a soft marker in aneuploid screening in the first trimester. A reversed AUF in the ductus is a soft marker. Remember the additional soft markers which we talked about when you are doing the combined test. So the combined test now has additional markers. The ductus venosus, if it is reversed flow, is also an additional soft marker. Then lastly, in the first trimester, cardiac defects. So a reversed AWF is not only an additional marker for aneuploid, but it's also a marker for cardiac defects. So when we see it in the first trimester, even if the aneuploid passes, then we book the patient for an early fetal echocardiography at 16 weeks and probably another one at 20 weeks. Then Dopplers are also useful in prenatal diagnosis of fetal anemia, so that MCA is not only useful in determining oxygenation in the brain, but you can also check what's called the peak systolic velocity, which informs us about if the baby has fetal anemia. How do we know that it has fetal anemia? If the peak systolic increases and goes above what we call 1.5 multiples of median. Fetal growth restriction, I think this one will be talked in subsequent, in greater detail, the usefulness of Dopplers. These Dopplers I was talking about when they become deranged in fetal growth restriction cases. Then it will also be talked about in greater detail in multiple pregnancy, TTTS, as well as TEPS. Then in fetal surveillance, then if a fetus has fetal anemia, and sometimes they get an intrauterine transfusion, then subsequent scans can be done to monitor if there is an improvement in the fetal anemia. As well as fetal growth restriction, just surveillance of fetal growth restriction in order to time the delivery, the best time for delivery. Then the improvement or worsening of TTTS and TEPS is also where Dopplers are used. All right, so that concludes my presentation.